etiology of adult congenital heart disease, an overview of the impact of congenital heart disease on pregnancy, and the risk of vaping and tobacco use in our community and patients. Our conversation features 4 regional ACHD providers and is sponsored by the University of Maryland Medical System. My name is Dr. Lisa Forbes, and I'm an adult congenital cardiologist at the University of Maryland, and I will be leading our Q&A after the presentation. At this time, I will turn it over to my colleagues.
Thank you to the American Heart Association for this focus on congenital heart disease today. I'm really excited to be here with my colleagues in the greater Maryland and greater DC area, Dr. Ari Cedars from Johns Hopkins and Dr. Anitha John from BC Children's. I'm Dr. Stacy Fisher. I'm with the University of Maryland and with the American Heart Association. I'm going to start our program today with a global issue that also significantly targets the adult congenital heart population, which is smoking and vaping. Of the approximately 480,000 Americans who die from smoking every single year, 35% of those deaths are from cardiovascular disease. Youth and adolescents are using new forms of tobacco, such as electronic cigarettes and vaping. This has skyrocketed, placing decades of progress at risk. Youth and adolescents are using new forms of tobacco, including one popular type called the Vuse e-cigarette. This product is becoming well known. It has 48 milligrams of nicotine per milliliter, or 4.8% by volume, where the average cigarette has 12 milligrams of nicotine. So these products are greatly increasing the nicotine dependence among our current youth. In congenital heart disease, we have a first generation of survivors of heart defects because of advances in pediatric heart surgery. Congenital heart disease involve a complex interplay between genetic and environmental factors, and smoking is part of that. Population studies show maternal cigarette smoking modestly associated with pulmonary valve anomalies, pulmonary artery anomalies, and isolated secundum types of atrial septal defects. Nicotine products and smoking in fathers before conception is also associated with higher risk of heart defects in the child. As children with birth defects become adults, they have the same pressures and exposures as other kids, and they may also get into smoking, vaping, and other nicotine products. Those with underlying cardiopulmonary disease are at even greater risk of short and long-term side effects, as they already have increased risk of heart rhythm problems, heart failure with shortness of breath, and lung injury from shunts or surgeries. Symptoms of too much nicotine can be even more severe and even more threatening in congenital heart patients with underlying heart disease. Symptoms of too much nicotine include sudden anxiety, feeling depressed, beginning to sweat excessively, terrible insomnia, becoming delusional, panic attacks, blood pressure increases, heart flutters and dizziness, feeling like body parts are falling asleep or tingling, diarrhea, joint stiffness, bad headaches, and nausea. So what is the American Heart Association doing to protect us from these products and to combat severe marketing attention to youth and young adults? Well, the American Heart Association has a legislative arm, and among many feats was the leading advocate for the landmark 2009 Family Smoking Prevention and Tobacco Control Act, which for the first time granted the FDA the authority to regulate the manufacture, distribution, sale, labeling, advertising, and promotion of tobacco products to protect our public health. I was able to testify in 2020 with the American Heart Association for a Maryland bill that passed, which prohibits the manufacture, sale, and distribution of cigarettes with characterizing flavors, such as menthol, and it restricts the retail, sale, and consumption of other tobacco products with characterizing flavors to smoking bars, prohibits the manufacture, sale, and distribution of closed and cartridge-based electronic smoking devices, and generally prohibits the direct sale or shipment of these products to a consumer by mail within the state. We know not to smoke. We know we need to prevent people, especially youth, from starting, and we need to discuss this openly and use available smoking cessation products and programs. This cannot be forgotten in the congenital heart community. It's a threat to the patients, to their survival, and to the really great outcomes that we're starting to see as children survive and become adults. We're gearing toward better and better and hopefully normal life expectancies over time, and smoking needs to be out of our population. If you're interested in getting involved with the American Heart Association, please join You're the Cure Grassroots Network. Now I'd like to introduce Dr. Ari Cedars, who is going to tell us about the epidemiology of adult congenital heart disease. It's all you, Ari.
Thanks, Stacy. Let me bring up my slides here. Give me a sec. So thank you to Stacy for inviting me and to the ACHA for giving me the opportunity to talk about this. For those of you who have congenital heart disease, I suppose you may have asked yourself, and I know I get a question from a lot of my patients, are there other people like me? Have you ever met anybody like me? Is there anybody like me who actually survives? And the answer is a resounding yes. There are quite a few of you out there. There are many adults with congenital heart disease, and your numbers are growing, particularly in the United States. But after that, I'm going to show you data from Canada, where you can see that at least since the year 2000, the number of adults with congenital heart disease has exceeded the number of children. And this is separated into two graphs here. The top graph depicts individuals with congenital heart disease of all different types, with adults indicated in red and the pediatric population indicated in purple. The bottom graph indicates those with the most complex forms of congenital heart disease, those who are at the greatest risk of dying during childhood. And even these at-risk individuals are now living well into adulthood, and their numbers exceed children in Canada and also we believe in the United States, although we have a harder time coming by numbers like this in the United States due to a lack of good administrative data. So does this mean that, everybody's doing great with congenital heart disease? And a lot of people are. And there's this is kind of an older manuscript, also again from Canada, where they looked at the age of death in the congenital heart disease population, which here is indicated by the yellow bars, compared to the general population. This happens to be in Quebec, Canada, and that's indicated by the little string of black dots. And you can see that in the mid-'80s, those who were born with congenital heart disease died far younger than those without congenital heart disease. However, within less than 20 years, it seems that the congenital heart disease population is living to a similar age of those in the general population. Now, I would say that this data should be taken with a grain of salt, because obviously those who were evaluated in 2004 and 2005 and were 80 years old or 85 years old were actually in their 50s to 60s in 1986 or 1987. And so we're talking about a group of people who were selected for survival. These are probably individuals who were either identified at an older age to have congenital heart disease because they had fairly mild or non-severe forms of congenital heart disease, or who had a very successful repair or an experimental repair at an early age that went well. And as a testament to the fact that this is probably an over-optimistic view of things, this is data from the Netherlands, where you can see that compared to the general population, again here indicated by the hashed black line, the age of death for those with congenital heart disease is substantially younger. And that goes for all forms of congenital heart disease. And while those with the simplest forms of congenital heart disease is indicated here by green line, they come pretty close to those of the general population. Those with moderate complexity or severe complexity disease, indicated by blue and red respectively, really die at a much younger age. And that's as a result of deteriorations of repairs that occur during childhood. And a lot of these deteriorations are things that potentially could be prevented if we identify them. And the way that many of these patients come into medical practice after childhood is they get hospitalized. We know this is, again, data from Canada. All my data is from Canada. That's because they have a good administrative data system. So this data, you can see that individuals with all forms of congenital heart disease, non-severe forms of congenital heart disease, I'm sorry, they're hospitalized at twice the rate of the general population in Quebec, as you can see between the rightwardmost bar and the middle bar. And compared to the general population, those with the most severe forms of congenital heart disease are over 3 times more likely to be hospitalized. And so, not surprisingly, they get hospitalized and they end up having bad outcomes. So, what can we do as a community to try and prevent this? What can we do to try and prolong life, prolong quality life, decrease hospitalization among adults with congenital heart disease? It turns out that specialized care is the key. And this is, again, data from Canada, and it shows something quite remarkable demographically. If you look in the top line, what you're seeing is the number of patients who are followed at an adult congenital heart disease specialized center. And you can see it's kind of tracking along with slow growth until around 1996-97, when the Canadian guidelines were published suggesting that adults with congenital heart disease should be followed at specialized centers. Then after the publication of those guidelines, doctors, being good little students, obeyed the rules and started referring more of their congenital heart disease patients to the proper centers. So that line starts to increase. But what's really remarkable about this graph is the bottom line, which indicates the death rate among adults with congenital heart disease. And you can see that within about only 3 to 4 years of publication of the guidelines, and within only 2 years of this uptick in referrals to specialized centers, the mortality rate on a population basis of adults with congenital heart disease starts to decline, suggesting, at least hinting, that there is a definite impact of these guidelines. But how do we know that it's not just the passage of time or some new developed technique that was responsible for this change? And if we look at those patients who are followed at adult congenital centers compared to those who are not followed at adult congenital centers longitudinally, you can see that survival of those followed at specialty centers, indicated in the solid line, is greater than those who are followed at non-adult congenital specialized centers. And so to conclude, I would say that the numbers of adults with congenital heart disease are increasing in the United States as they are in Canada. Even though I don't have the data to show you about the United States here, we know that at least 1.4 million adults in 2016 in the United States were living with congenital heart disease. Ironically enough, that number comes from an analyst in Canada. But we know that the numbers are growing in the United States, and we know that the best intervention that we can have for patients with congenital heart disease is to make certain that they're followed by specialists who are familiar with their lesions, familiar with their repairs, and familiar with the unique ways in which their physiology and repairs may deteriorate over time. Thanks, Stacy.
Thank you, Ari. That is amazing data and really very helpful. Now we're going to turn to Anita John, who's the director of the DC Children's Adult Congenital Heart Program, and is going to talk to us today about pregnancy and adult congenital heart disease.
Great. Thank you so much, Stacy. I appreciate the opportunity to join all of you. I'm trying to see if I can get this to move into slideshow. Here we go. So that was a perfect segue into the topic that I wanted to speak to you about, which is the management of pregnancy in patients with congenital heart disease. So as Dr. Cedars pointed out, the number of adults with congenital heart disease is increasing throughout the globe, but definitely within the U.S. And as that number increases, the number of women who are of childbearing age who also have underlying congenital heart disease is also increasing. So not surprisingly, the number of annual deliveries for women has increased by 35% if you look at the time period between 1998 to 2007. Has increased by 35% for women with congenital heart disease, as opposed to 21% for women with no underlying congenital heart disease. This data is from the national inpatient sample. It's definitely not anywhere close to as robust as the administrative data sets that they have within Canada, but it is data that comes from within the United States. From this paper, we also saw that women with congenital heart disease are 8 times as likely to have a cardiovascular event, with arrhythmia being the most common There is an increased risk of death, and women with complex congenital heart disease are twice as likely to have events as those with non-complex disease. The good thing is when you really look at various centers and look at risk stratification scores for women with congenital heart disease, most women do very well throughout pregnancy. But it is important to know that there are special screenings and special considerations that need to be considered depending on what your underlying congenital heart defect is. So as Dr. Cedar said, we don't really have a way to be able to track outcomes in patients long-term within the United States. So this was an initiative that we started off about 3 years ago. Dr. Cedars was part of this and helped spearhead this at the beginning. The Congenital Heart Initiative is the first patient-powered registry for adults with congenital heart disease. This has been in the process of being built within the United States over the past 3 years and launched last December. And so I wanted to share some of the data here because one of the questions that I often get asked by women when they come in and are contemplating pregnancy is, what are their long-term outcomes? How many women are there with underlying CHD that have gotten pregnant? How do they do long-term? And unfortunately, we don't have great data to be able to tell patients about this. And certainly we don't have a lot of information from patients directly. So this registry aims to be able to collect information from the patient directly, and we hope to be able to combine it with medical records at some point in the future. But I wanted to sort of show you some of the information that we've gathered from here, specifically with regards to women who've undergone pregnancy. So the registry, as I said, launched back in December, and as of the end of the summer, I believe as of end of August, about 1,300 patients had signed up and 1,100 had consented to complete the surveys that we administer through this registry. You can see most of the folks who have participated are from the US, although we did have representation from 17 different countries, but about 98% of the participants are from the United States. When we look at the demographics, the vast majority of people who actually signed up were women. So about 73% of the entire cohort were women. And this is, again, looking at the first 1,000 or so patients who signed up. And we have a pretty good age distribution. So there's a good range throughout all of the different age categories. When we look at educational attainment, I think we are a little biased in the sample in terms of the folks who are signing up for this. And we don't have a great breakdown in terms of diversity, but this is something that we are working on. As part of the information that we collect on patients, we do collect some demographic information, so we get an idea of what their marital status is, and we've also asked whether or not participants have children. So you can see about half of the participants, male or female, do have children, and when we look at the female participants with children, so the women who have kids, there are about 311 who have biological children. And when we further break them down, you can see the distribution of the underlying congenital heart defects. So there's a variety of different types of congenital heart defects amongst the women with biological children, and we're hoping to sort of be able to do additional analysis to see how these folks are doing, as many of them had their pregnancies some time ago. And so hopefully we'll be able to get a better idea of how patients are doing long term. But as you can see, there are lots of women out there who are having kids and having families successfully. I think something that is really important to note for women who are undertaking pregnancy is the presence of a high-risk pregnancy program. So as I said, most patients with congenital heart defects do great, but I think it's really important to have discussions with your cardiologist, and hopefully you are being followed at a specialized center. And if you are in need of a high-risk pregnancy program, different components that go into that are not only the cardiac team, along with all the various cardiac subspecialists, but access to maternal fetal medicine specialists. These are specialized OBGYNs who take care of high-risk pregnancies. They often bring in different expertise in nursing, both cardiac and obstetrical nursing, to offer opinions and to assist with care for patients. OB and cardiac anesthesia is often part of this team as well, too, as are social work psychiatry. And then it's also important to remember to keep in mind the baby and the fetus as well. And so neonatology is often part of this team as well. So not everybody requires input from all of these different services, but if you are somebody who has an underlying CHD that places you at high risk, you really want to make sure you're sort of at the center of care, and that your needs and your child's needs are really being taken care of. Something that we've established at Children's National is a partnership with MedStar Washington Hospital Center and the development of the Special Moms, Special Babies program. This is led by Dr. Melissa Fries, and it's really focused on the care of pregnant moms with underlying health disease. We've taken care of many of patients with congenital heart defects, especially those with high-risk lesions, but they also care for moms who are carrying babies with congenital health problems as well. I think some additional things for folks to consider is really the best time to think about what to really keep in mind during a pregnancy is before you get pregnant. So having a preconception evaluation with your cardiologist is really important. I always tell folks, really, when you start thinking about it, come in to talk to us, because if there are any things that need to be addressed prior to a pregnancy, it's much easier to have that conversation before you're pregnant than afterwards. Some patients also have to undergo a genetic evaluation. Mothers who have underlying tetralogy of Fallot, it's recommended that you have a screen for 22q11.2 deletion syndrome. And there are various other genetic evaluations depending on what your underlying CHD is. We usually recommend that patients have a prenatal echocardiogram to ensure that your baby's heart is okay. And then really to work closely with your cardiologist and your maternal fetal medicine specialist or your OBGYN as to a pregnancy management plan. This will include where you're going to deliver, whether or not you need a C-section or whether you would be fine with a vaginal delivery, any particular considerations with regards to your medications. These are all things that really should be developed as you move forward within your pregnancy in consultation with your care teams. Something very important is contraception. So after pregnancy, it's important to really think about the future and making sure you're on appropriate contraception and to avoid unplanned pregnancies. Not all women with congenital heart disease can take estrogen-containing contraception, so that's another thing to really discuss with your cardiologist and with your obstetrician as well. Of course, there are always two patients to evaluate, which is why we always keep the baby in mind as well, and really having a team approach is important. So with regard to the registry, I think it's great to have more and more data. So if you are interested, you can register yourself. This is the website. There's a lot of information on the registry and some different videos that you can watch to learn a little bit more about the process. This helps us really gather data on patients as we're moving forward with this endeavor, and really will be able to provide more information in the care of women with congenital heart disease who want to undertake pregnancy. So that's all I have from my end. I just want to thank Stacy again and the American Heart Association for the opportunity to speak and to be here with all of you today.
Well, thank you both. And I also want to thank the American Heart Association. We're going to open it up to questions and discussions. And I have to say one comment is that looking at what Dr. Cedars presented and into what Dr. John presented, it is amazing that congenital heart care has really formalized, that we take a team approach, which I see every day improving congenital heart decision-making, diagnostics, discussions and care, and groups like the maternal fetal medicine and congenital heart teams joining together definitely improves care. It also improves the knowledge base and training so that we can try to get more care out through the country and into every single decision that we make and recommendation that we give. We also use our colleagues, so it's really nice to see you both. And collaborate regularly with you both. And thank you for coming today.
Thank you so much for those outstanding presentations. And now we would like to open it up for questions and answers. Well, I guess I'll kick it off then. And I get this question quite a bit. When we diagnose congenital heart disease for the first time in adult, people often wonder how that's possible, and they actually can be a little bit upset about that and wonder why they hadn't noticed things sooner, and then wonder how they differ from someone who is diagnosed in childhood. I'll try to turn my camera on. I guess I'm not able to turn my camera on. I guess the host seems to be blocking it. So hopefully y'all can hear me okay and write in some questions. But Dr. Fisher, would you like to take that question about the adults diagnosed for the first time with congenital heart disease?
Sure. So some people actually have noisy findings, and some people have very quiet findings as far as physical exam, where when people go as infants or young children to the doctors, the louder lesions are generally found earlier.
There we go. Now we can all get cameras.
So louder lesions are going to be found earlier often, and bigger lesions are things that make people short of breath or have palpitations earlier in life are things that are going to make them come to the doctors earlier. Some of the slower and more progressive problems, like a hole in the heart that may have some flow but not overwhelming flow, may be something that causes damage over time, but not so early in life. So that people may show up when they have other challenges like a gallbladder surgery or a pregnancy, or they may show up with rhythm changes that happen because of stretching of the heart tissue itself. So people get into trouble with underlying issues. One of the things that I care about a lot also is this tobacco issue, and also energy drinks, where teenagers and young adults are the ones that are showing up the most, may have an underlying condition, be unaware of it, and be susceptible to the extra work that's required from the heart and the cardiovascular system to support the challenge that these toxins cause.
Fantastic. Anybody else would like to add anything to that? Okay, I know certainly you mentioned pregnancy, and that's certainly a very common and quite a stressful time to be diagnosed with congenital heart disease and be pregnant. But the good news, as Dr. John mentioned, is that actually most of our patients can do well. Of course, there are exceptions, and there are some women that we are very concerned about, and certainly we want people like that to certainly have a good team, including maternal fetal medicine and the cardiologist and whatever else is needed. So that certainly should be in a highly specialized center. Trying to see if there are any questions that have come in. So we have one here. With all the improvements we are seeing, where do you see the biggest gaps? Dr. Cedars, would you like to take that one?
Sure, I think that there are a lot of gaps. Unfortunately, it's hard to do good research in adults with congenital heart disease due to the heterogeneity of the population and its comparatively small size. For that reason, I think a lot of the therapies that we use when we're taking care of patients with congenital heart disease are largely based on extrapolation from data in people with normally developed hearts. So we could really use, there's a huge gap in knowledge that's disease specific for adults with congenital heart disease. But based kind of springboarding out off of the data I presented in my presentation, indicating that getting regular care at an adult congenital heart disease specialized center, I believe that if we were better able to see what was going on with our patients in the time in between visits, we could get more clinical data derived from patients themselves, patient-focused data, that I think that could really be of benefit in decision-making at the time we see the patients, and could lead to better care. So those are kind of the two big areas I think could really be improved.
And I would just add one thing that was brought up in the chat was really, access to care, and we really are making effort to educate more providers in this area. It's definitely an underserved population, and a lot of you may not know that it was only in 2015 that the American Board of Internal Medicine for the first time offered board certification in congenital heart disease. So we really are training a new generation to help care for these kind of patients. Let's see, one other question that's come up. Let's see, could anxiety and depression be related to a congenital heart defect? Dr. John, would you like to tackle that one?
Sure, I'd be happy to, Dr. Forbes. Thank you. So I definitely think it could be related to your congenital heart disease. That's one thing we've found from the Congenital Heart Initiative. We've asked patients about various different other health issues that they have, other comorbidities, we call them. And by and away, the most common one that people have reported are mental health issues like anxiety and depression. About a third of our population that have responded within the registry indicated that they've had some history of this throughout their life. And interestingly, it really doesn't have to do with the severity of your heart defect. So there are folks who have had lots of surgeries and, come to the hospital frequently. And there are folks who don't. And it's really seen sort of all throughout. And I think there are probably a lot of reasons for that. But I think one of the big things, as Dr. Cedar said, is really getting to a point where you have access to care is really important. Certainly, most congenital heart centers, I think because we see it pretty frequently in our patients, have folks that we readily refer to. But I think even working with your primary care physician to address those issues early are really important. Things that have been published in the literature have shown that even though anxiety and depression are very common in the congenital heart population, many patients are not receiving adequate care. So it's not just your heart. I think you really have to think about all of the things that might be associated with that and really capitalizing on your medical team to help you find the appropriate treatments.
And just to add things to that, there's a chicken and an egg question here. Is my heart giving me palpitations and that's making me anxious, or am I anxious and that's affecting my heart issue? So I think that's a really important thing to actually discuss with your heart doctor. A lot of times you can do monitoring. The new wearable technologies can be very helpful in distinguishing, am I actually having a problem with my heart rhythm that's making me feel anxious, or is the anxiety making me more aware of the heart rhythm? The other thing is that with the diagnosis of heart disease, there's always a mortality awakening that people have, and especially around a new diagnosis or around a heart surgery. So using support groups for congenital heart disease is very helpful in meeting some survivors. For example, the American Heart Walk on Saturday, there will be survivors of adult congenital heart disease that you can see walking with you, that you can experience and share stories with, and realize that there are survivors now where in, say, 1960, 1970, people didn't survive with congenital heart disease. So that awareness of the mortality we all feel, we all address, and you should be discussing openly with your providers.
Thank you, Dr. Fisher. And another issue brought up here is that there is hope for many that future operations and procedures will be significantly less invasive than they used to be. Could you give an overview? I'm happy to answer that because this is just so exciting for our patients that we've seen dramatic changes just in the last 20 years with transcatheter techniques. We can now put heart valves in the cath lab. And what I often tell patients is that I don't mean you won't ever have to have an open heart surgery again, but I'm pretty confident we can decrease the number of times you will have surgery. And this is very exciting for us. We have lots of ways to make intervention with metal expandable stents when there's narrowing of blood vessels. And even for some patients who are diagnosed as an adult, sometimes the only treatment they need is a stent, for example. So there's really exciting opportunities with new valve technology in the cath lab. And I'm happy to open this up to anybody else. We actually close holes in the heart, atrial septal defects. We can close ventricular septal defects in the cath lab. So, we don't always even have to operate at all. So this is certainly very exciting, and the future is very bright in this area. Let's see, there's some other ones that are coming up. Are there some conditions getting better with exercise and conditioning? So that's something we talk about quite a bit with our patients. Is most of the time we want our patients to be active. Of course, we want them to listen to their bodies, and we are pretty specific with certain patients on really what they shouldn't do. And there are some issues that certainly come up with very young patients on maybe there's some occupations that aren't going to be the best for them given their congenital heart disease. And that's certainly something we talk about with our patients, hopefully as soon as we meet them, you know, what they are doing, what their life goals are, and do talk about activity. And I do have an anecdote to share is when I first moved to Chicago, I took on a young patient that had been followed by a pediatric cardiologist. And he said, I'm planning to hike the Appalachian Trail for the next 6 months. And he had rather complex congenital heart disease and made me think long and hard. And we did a pretty thorough evaluation. And he had an incredible plan worked out with his family where he would check in. And he did it. I was a little nervous, but he made it his 6 months and it was fantastic. And he got to achieve a life goal. And I'm sure some of these other folks have some other anecdotes they would like to share or give any other comments. Anyone?
I would just say only that congenital heart disease by and large is anatomical. And so it's unlikely that lifestyle modification will actually substantially affect the disease itself. Although, as Dr. Forbes was alluding to, everybody can benefit from healthy lifestyle choices, remaining physically active and eating healthy, because there's nothing about being born with congenital heart disease which somehow magically protects you against good old-fashioned acquired heart disease. And the way that those two pathologic processes may kind of play not so well together long-term is something that you don't necessarily want to discover on the wrong side of. So I think that it is important to stay healthy, but you can't fix congenital heart disease per se with lifestyle modification.
But I also can't understate the interplay, and a lot of what we do taking care of adults is trying to help minimize the obstruction from the anatomical issues. So, for example, for people on this webinar, it's really important that you look at your life choices, your lifestyles, and what you're planning. So, for example, if you need a surgery coming up, a knee replacement, that you actually work through where are you with your anatomical issue and how does your lifestyle play into that, and what is your coronary risk, what is your family history for regular things, because the congenital heart does not protect you from the regular things. So one anecdotal issue is I had a patient who really didn't want to look at her BRCA gene that ran in the family or get breast cancer screening because she really didn't think that she would live long enough to deal with breast cancer. And at 49 years old, she's dealing with the breast cancer primarily and the congenital heart disease secondarily, and maybe it would have been preventable. So I think that we need to look at the whole picture and the interplay as people survive and become older, which is our goal. Our goal as a community is to normalize the life expectancy and experience.
I couldn't agree more. I would, like to reinforce that, telling you can't help that you were born with, a congenital heart problem, but you can take good care of yourself, eat right, exercise, avoid the bad things like excessive alcohol, smoking, recreational drugs. And certainly the other thing is what runs in your family. If high blood pressure, diabetes, and coronary disease run in your family, we really want to be aggressive with trying to keep you as healthy as possible, because we are seeing patients with congenital heart disease develop other complications because of their genetic predisposition. Well, I'm told that we should try to get any last comments from our panel as we need to kind of wrap things up. Dr. John, do you have any last words for the group?
No, I think this is great. I think I want to thank Dr. Fisher and you and the American Heart Association again for organizing this. I really appreciate being part of this. I think emphasizing what everybody has said about taking your health into your own hands and keeping the whole picture in mind, I think is really important for overall health and longevity for our patients.
Thank you. Dr. Cedars, last words?
Just for those who have congenital heart disease, make sure that you follow up with a specialist. Doesn't matter where you follow up, find somebody near your house, somebody you have a good relationship with, but it really can have an impact on your overall outcome.
Dr. Fisher?
I want to thank the American Heart and all of you. To everybody on here, the region does care about you. Our region, thankfully, has very strong providers, collaborative providers, people that care about you and want you to have a good outcome. Make good choices. Let us know if you have something upcoming, like a surgery, a pregnancy plan. Try not to do these things without planning and talking to your providers and optimizing your health. So I think in this era, optimization is really critical in having a great outcome. And that's what I'd encourage you to do.
Well, thank you again to our doctors for their great presentations, and thank you for the wonderful questions through the chat. The congenital heart disease community is continuing to grow and relevant to many lives today. And I'd like to remind everyone about the Greater Maryland Heart Walk this Saturday at Camden Yards Sports Complex, and we hope to see many of you there. And thank you again, everyone.
Bye, everybody.
Bye-bye.